What if you could get Wegovy or Zepbound, drugs that can help you lose 20% of your body weight or more for just $50 a month? No, this isn't a commercial. Starting July 1st of 2026, just a few weeks away, that's actually happening for millions of Medicare recipients across the country. But how we got here, that's a story involving a decades old law, a last minute Biden rule, Trump killing that rule, and then Trump bringing it back and claiming full credit. Stick with me because this is a wild ride. Welcome back. This is my weekly series, The Weekly Shot, where I bring digestible breakdowns regarding GLP-1 news. I'm Charles, also known as RMZ. Today, we're breaking down one of the biggest healthcare stories about to go in effect in just a few weeks. Medicare finally covering GLP-1 weight loss drugs at a price that millions of older Americans can actually afford. Maybe. We're talking about medications like Wegovy and Zepbound, the same class of drugs as Ozempic, which has basically taken over pop culture at this point. But this story isn't just about the drugs, it's about the political ping pong that got us here. A law passed over 20 years ago, born out of a genuine medical scandal, and the very real limits of what this program can actually do and how long it can last. Let's get into it. So, here's what's happening. Starting July 1st of 2026, Medicare is launching what's called the GLP-1 Bridge program. Under this program, Medicare recipients who qualify can get popular GLP-1 weight loss medications, specifically Wegovy, Zepbound, and a newer daily pill called Foundayo for a copay of just $50 a month. To put that in context, these drugs currently cost anywhere from $450 to $1,000 a month or more without insurance. We're talking about an enormous reduction in cost for people who, until now, have simply been priced out. Now, not every Medicare recipient qualifies. The eligibility criteria has tiers. The broadest group, people with a BMI of 35 or higher, can qualify based on obesity alone. A middle tier covers people with a BMI of 30 or higher who have a specific condition like heart failure, uncontrolled high blood pressure, or chronic kidney disease. And a third tier covers people with a BMI of 27 or higher who have a history of heart attack, stroke, prediabetes, or peripheral artery disease. If you don't fit in one of those three buckets, you won't qualify, at least not for this program. If you have diabetes, you're not part of this program either. Medicare already covers GLP-1s for diabetes, so there's a separate track for that. And yes, you do need a Medicare Part D drug plan to access this benefit. The federal government, specifically CMS, or the Centers for Medicare and Medicaid Services, is picking up the tab directly for the first 18 months, rather than routing costs through private insurers. That's actually a big part of why they're calling it the Bridge program. It's meant to be a bridge while they figure out the long-term structure. Here's where it gets interesting and a little political as well. So let's be clear. This is not a story that started with Trump, not even close. Back in November 2024, as Biden was wrapping up his presidency, his administration proposed a landmark rule through CMS. The idea was to reinterpret the existing law to allow Medicare and Medicaid to cover GLP-1 medications for the treatment of obesity, not just for diabetes or heart disease, but specifically for weight loss itself. This was actually a big deal because the existing law explicitly prohibits Medicare from covering drugs used for weight loss. Biden's team argued that if doctors are prescribing these drugs to treat obesity, a recognized chronic disease, then the prohibition shouldn't apply. It was a creative legal argument and it generated nearly 25,000 public comments, the vast majority of which were supportive. Patients, doctors, and drug manufacturers were largely on board. But then January 2025 rolled around and a new administration took over. On April 4th of 2025, the Trump administration officially killed the Biden rule. CMS said it was not finalizing certain provisions from the prior proposal, including the expanded GLP-1 coverage. No detailed explanation, just a terse notice and a line saying they may address this proposal in future rulemaking as appropriate. Health insurance companies had lobbied against this rule hard, arguing that covering GLP-1s for obesity would be enormously expensive and that premiums would have to rise to cover the costs. The Congressional Budget Office had estimated the policy would cost the federal government around $40 billion over 10 years, though some researchers argued that the health savings from reduced obesity-related disease could more than offset that over time. So at that point in April of 2025, Biden's rule was dead. Medicare was still barred from covering GLP-1s for weight loss. RFK was publicly recommending 3 good meals a day instead of medication, and the prospects looked pretty dim. Now, to be fair, this move by Biden was a post-election move, probably sit there as a poison pill to the Trump administration, no pun intended, and Trump likely killed it so he could bring it back in one way or another and take credit for it. Politics, right? Which leads me to this, a complete reversal. November of 2025, President Trump stood in front of cameras and announced what he called a landmark deal with pharmaceutical companies Eli Lilly and Novo Nordisk. Under the agreement, both companies would dramatically cut the prices they charge Medicare and Medicaid for GLP-1 drugs. In exchange, Medicare will begin covering these medications for obesity for the first time ever. Trump touted this as a signature achievement of his administration, framing it as a win on drug pricing that no one had ever managed before. In a technical sense, that's true. The math is different from what Biden proposed. Rather than a regulatory reinterpretation, Trump's approach used a CMMI demonstration model. That's the Center for Medicare and Medicaid Innovation, which has the authority to waive certain Medicare rules as part of a pilot program designed to test whether covering these drugs saves money or improves health outcomes. The original plan had 2 steps. First, the Bridge program, a short-term CMS-run demonstration starting on July 1st of 2026, designed to get the benefit moving quickly without requiring private insurers to take the financial risk. Second, a long-term follow-on called the Balance Model, a 5-year pilot where private Medicare insurers would pay for GLP-1s as a regular benefit, originally scheduled to kick in January of 2027. But there was a problem with step 2. Private insurers didn't want to play. They'd be taking on a massive financial risk for a new, expensive drug benefit with uncertain utilization data, and they pushed back hard. By April of 2026, CMS announced it was indefinitely delaying the Medicare portion of Balance. Rather than a clean handoff from Bridge to Balance in January of 2027, the Bridge program was extended through the end of 2027 to fill the gap, with no firm timeline for when or whether Balance will actually launch for Medicare Part D. So, where does that leave things? The Bridge program runs July of 2026 through December of 2027. CMS says it will use that time to collect utilization data to share with insurers, hopefully building the case for Balance eventually. But as of right now, Balance for Medicare is delayed indefinitely, and the Bridge is the only game in town. Now, let's be honest about what happened here. The substance of the policy, Medicare covering GLP-1s for weight loss, is essentially what Biden proposed, whether it was a poison pill or not. The mechanisms are different, though. The political branding is entirely different as well. But the outcome for the patients, remarkably similar to what Biden wanted in the first place. Now, here's something that hasn't gotten enough attention in the mainstream coverage of the story. Both Biden's approach and Trump's approach are temporary workarounds, not permanent fixes. And the reason comes down to a law passed over 20 years ago when Congress created Medicare Part D, the prescription drug benefit, in 2003. They explicitly wrote into the law that Medicare could not cover drugs used for weight loss. That prohibition is baked into the Medicare Prescription Drug Improvement and Modernization Act of 2003. Where did that prohibition come from? It came from two places. First, it was modeled on an existing Medicaid exclusion that had been on the books since 1990. At the time, the thinking was that weight loss drugs were largely cosmetic, a lifestyle choice, not a treatment for a recognized disease. Second, and this is the part that's genuinely fascinating, Congress was thinking about a drug called fen-phen. Now, if you're not familiar, fen-phen was a combination weight loss drug that was enormously popular in the 1990s. The media called it a miracle. Millions of people took it. And then researchers discovered that in some patients, it caused fatal heart valve damage. The manufacturer pulled it from the shelves in 1997, just 6 years before Congress was writing Medicare Part D. So, when those lawmakers sat down in 2003 to build the prescription drug benefit, the fen-phen disaster was fresh in their mind. The drugs available at the time for weight loss had limited effectiveness and real safety concerns. The attitude in Congress and, frankly, in much of the medical community was that obesity was a behavioral problem, not a medical condition, and that weight loss drugs weren't worth the risks or the costs. That decision, made in 2003 in the shadow of fen-phen, is now the fundamental legal barrier standing between the current bridge program and any permanent Medicare coverage of GLP-1s for weight loss. And here's why that matters. Right now, the CMMI, the Innovation Center that is enabling the current bridge program, has authority to run pilots and waive certain rules, but only temporarily. Demonstration models through CMMI are time limited. The bridge program explicitly runs through the end of 2027. After that, without a new law, the coverage goes away. And there's an even bigger issue. CMMI's authority to extend or make permanent a model is limited. Under federal law, a CMMI model can only be scaled up or made permanent if it has been shown to either reduce spending or maintain quality without increasing spending. Whether the bridge program will meet that bar is genuinely unknown. We are still in the early stages of all of this. So, what's the path to a real durable solution? The honest answer is that Congress needs to change the law. The 2003 Medicare Modernization Act would have to be amended to remove the prohibition on covering weight loss drugs. Until that happens, every administration, whether a Democrat or Republican, is working around a legal barrier and not through it. Now, there is legislation that has been introduced to do exactly that. It's called the Treat and Reduce Obesity Act, and versions of it have been circulating in Congress for years. It would authorize Medicare Part D to cover FDA approved obesity medications, but as of this recording, it has not passed. The political obstacles are real. The Congressional Budget Office estimated that fully covering GLP-1s under Medicare Part D could cost the federal government roughly $40 billion over 10 years before accounting for savings from reduced obesity-related disease. Some researchers argue the long-term savings could far exceed the upfront costs. One University of Southern California study, Fight On, estimated it could save Medicare more than $175 billion over a decade. But the upfront number is what the CBO scores, and that's what Congress has to vote on. And there's another layer here. Even if Congress changed the law for Medicare, Medicaid is a separate story. Each state Medicaid program makes its own coverage decision, and while the Trump deals with Eli Lilly and Novo Nordisk established discounted prices for state Medicaid programs, it's up to each state to actually opt in. And currently, only about 13 states cover GLP-1s for obesity through Medicaid, and some are actually cutting back even more due to budget pressures. Now, let's step back and think about what's actually at stake here. More than 70 million Americans are on Medicare. And in the United States, roughly 40% of adults are clinically obese by the standard BMI measure. If we use the new obesity definition, that number could jump up to 70% of adults. That's a massive overlap of people who, up until now, have been locked out of the most effective weight loss medications on the market simply because they couldn't afford them. These drugs work. Clinical trials have shown GLP-1 medications can help people lose up to 20% or more of their body weight. They've been shown to reduce heart attacks and strokes. They can eliminate sleep apnea. There's emerging research suggesting that they may reduce cancer risk and help reduce cravings for alcohol and other substances. The catch, people generally have to stay on them long term. Now, when patients stop taking GLP-1s, they typically regain the weight. That means a permanent Medicare benefit wouldn't just be a short course of treatment. It would be an ongoing, indefinite expense for the program. That's part of why the Bridge program is called a bridge. The idea is to gather data, how many people actually use the drugs, what the health outcomes look like, whether the costs are offset by reduced hospitalizations and chronic disease treatment before Congress or CMS makes a more permanent call. There's also an equity angle here. GLP-1s at $1,000 or more a month have been a drug for the wealthy. The Bridge program, even at $50 a month, isn't free, and some patients living on fixed incomes may still struggle to afford it. But it's a meaningful step towards broader access, particularly for lower income older Americans and communities of color who have higher obesity rates and have historically had less access to these very medications. If you're on Medicare and think you might qualify, here's what you need to know. First, you need Medicare Part D. If you don't have a Part D drug plan, you'll need to enroll through a private insurer. So while the copay for your GLP-1 may just be $50, you will have the added expense of signing up for Medicare Part D if you're not already on it. And here's a financial detail that almost nobody is talking about. Because the Bridge program operates outside of the normal Part D payment flow, your $50 monthly copay does not count towards your annual out-of-pocket spending total, what Medicare calls your true out-of-pocket or TRUP. That means if you're trying to work through your Part D deductible or hit Medicare's $2,000 annual out-of-pocket cap, these payments won't help you get there. Now, it's not a deal breaker, but it's something to factor into your planning and worth discussing with your Part D plan administrator. Second, you need to see your primary care doctor and ask specifically about the covered drugs. That means Wegovy, available as either a once weekly injection or a daily pill, Zepbound via the quick pen injector, or Foundayo, the new once daily pill from Eli Lilly. Make sure your doctor prescribes one of these specific formulations because not every version of these drugs will qualify for the $50 copay under the Bridge program. Now, third, expect a prior authorization process. Your doctor will need to document that you meet the BMI and clinical criteria. This isn't instant, and there will likely be a surge in demand when the program launches on July 1st. Be patient, but be persistent. Fourth, be prepared to start at the lowest dose and work your way up. These medications are titrated, meaning you start small and gradually increase, which helps your body adjust and reduces the common side effects that everyone seems to feel. And here's something important for a group that isn't talked about enough. What if you're already on one of these medications, paying out of pocket or through private insurance, and you've already lost a significant amount of weight? Can you switch to the Bridge program to maintain that weight loss? The answer to that is yes. The Bridge program explicitly allows people to use these drugs to maintain weight loss, not just actively lose it. This is actually a really important detail because the medical reality is that if you stop taking a GLP-1, the weight typically comes back. The drugs don't fix the underlying biology. They manage it the same way blood pressure medication manages hypertension. If you stop taking it, the problem will return. So, if you're a Medicare recipient who has been paying $450, $500, or maybe $1,000 a month to keep the weight off, and your BMI when you first started the medication met those thresholds, You should talk to your doctor about switching to one of the covered formulations under the Bridge program. You may be able to dramatically cut your monthly costs while continuing your treatment. Just be aware that you'll need to switch to one of the three covered drugs, and you'll still need to go through prior authorization, even if you've been on a GLP-1 for years. Now, here's the bottom line. The Medicare GLP-1 Bridge program is a genuine, meaningful step forward in making these drugs accessible to the people who need them the most. But it's also a temporary fix sitting on top of a 20-year-old legal barrier, a barrier that was itself built on the wreckage of Fen-Phen. Whether it's Biden getting the credit, Trump getting the credit, or nobody's credit, it probably doesn't matter as much as whether Congress eventually steps up and changes the underlying law so that millions of older Americans don't have to worry about this benefit disappearing when the political winds shift again, and they will. I'll keep covering this as it develops. If you found this helpful, share with someone on Medicare who needs to know about this. Leave a comment with your thoughts, especially if you've had your own experience with GLP-1 medications, and subscribe if you want more explainers exactly like this. And if you're watching on the mobile app, make sure that you hit the hype button after you hit the like button. It'll help me out. I'll see you on the next one.